Chapter 13, Infusion Therapy. In this chapter, we will look at the different types of priority concepts, looking at fluid and electrolyte balance, tissue integrity, infection, and perfusion. Also, know that infusion therapy is the delivery of medications in solutions and fluids by parenteral, piercing the skin or mucous membranes, route through a wide variety of catheter types and locations of multiple procedures. We're talking about this because this is the number one way of which we administer medications in acute care setting. So we're getting ready to dive into chapter 13. Infusion therapy. Delivery of medications and solutions and fluids by parenteral route. And like I said earlier, that it's the most common route that we use in acute care setting. IV therapy is a common invasive therapy, and it's administered for hospitalized patients. Also know that as nurses that we have the scope of practice to basically insert peripheral IV lines and maintain other lines according to the facility's policy, such as a PICC line and a central line. The RN is ultimately accountable for all aspects of the infusion and delegation of the associated tasks. The other thing that, depending on where you practice, the Nurse Practice Act will give you permission to do certain things. So as far as an LVN, if you're an LVN currently, you are to manage IV fluids, and you are to monitor IV fluids, and you are to monitor blood products. However, if you are an RN, you can actually start IV fluids and manage them. Such as blood products, you can do the same thing. You can start them with another witness, and you can manage them according to your scope of practice. As far as a specialized infusion team, they are specially trained nurses that initiate and maintain IV infusions. They also have a responsibilities to develop evidence-based practice policies and procedures, insert and maintain various types of peripheral and central venous lines, monitor patients' outcome with infusions, educate staff, patients, and families regarding the infusion, consult on a product selection and purchasing decisions, and they provide therapy such as blood withdrawals, therapeutic phlebotomy, hypodermoclysis, intraosseous infusions, and administration of medication, including chemotherapy. So this is what specialized nurses do. Also, I'm sure you've seen it in the facilities that you've been working in or even doing clinicals in. Only certain nurses can DC PICC lines, which are your peripheral intravenous cutaneous catheters. And so basically what happens is just a regular nurse that has not been through training cannot DC it. But in the specialized team, if you've been trained, you can actually insert it and DC it. So it's something to think about if that's something that you want to do, or get that specialty behind your belt. So the type of infusion therapies that we utilize are IV solutions, including parenteral nutrition, so including TPN, total parenteral nutrition, blood products and blood components, including like fresh frozen plasma, and then drug therapy if it's a piggyback such as an antibiotic, or it could be an electrolyte such as potassium. Okay, so the intravenous solutions that we oftentimes utilize for fluid replacement are isotonics, which we talked about this the other day when we were talking about fluid and electrolytes, understanding osmolarity, which talks about concentration. An isotonic solution is 270 to 300, and it's basically the same fluid volume with concentration that's actually in your body at this time. Hypertonic is you have a greater amount of osmolarity, so you have greater than 300, so you have more particles or more solutes. And then hypotonic is you have less than 270, and so that means that you have more of the solvent instead of the particles. Of course, looking at these isotonic solutions are your normal saline, or 0.9%, which is your sodium chloride or normal saline, and then you have your lactated ringers and your D5W, and then hypertonic solutions is 3 to 5% normal saline, and hypotonic solutions are your 0.45 normal salines. Those are just some examples. So the question is, when would you need an isotonic solution? So if you're just trying to hydrate the extracellular fluid because there has been minimal loss, this is the type of fluid that you would administer. So the water does not move into or out of the body cell. It just stays there. However, if you give too much of an isotonic solution, especially to your newborns, so your younger population or your older population, it could set them up for risk for fluid volume overload. So you can actually push more fluid into the cells. Hypertonic solution, we're looking at normal saline 3% or normal saline 5% is correct fluid and electrolyte and acid and balance by moving the water out of the body cell into the bloodstream. So hypertonic solution, remember, you are doing what to the cell? You are shrinking the cell. So basically you're taking more solvent and pushing it outside. So you're moving water out of the body into the bloodstream. This is usually done by an example of parental nutrition. Total parental nutrition is utilized when people have issues with their GI tract and they need a sustained continuous amount of nutrition coming in. So this is where an example is used for that one. Hypotonic insulfated is hypotonic solution, which means we move water into the cell and it expands them. So basically, hypertonic solution will cause the cell to swell because you have an increase of solvent going into that cell. Okay. So looking at the slide, it just is a memory tool for you. It says if the osmolarity is greater than 600, which means that this client is very hypertonic, you must utilize central circulation to provide this fluid inside of this patient. TPN has an osmolarity of greater than 1400, so therefore it should not be administered in the peripheral circulation. So you always got to administer this through a central line. The reason why you cannot administer it through the peripheral circulation, it can damage the blood cells and the vein. Before moving on to blood transfusions and other components, I wanted to take time out just to review some things in reference to IV solution. Phlebitis is inflammation of the vein. Usually you have a red line and you have heat with phlebitis, and then infiltration is basically when the catheter comes outside of the vein, and so the solvent is actually going inside of the subcutaneous tissue. Therefore, when you palpate and infiltrate, it'll be cool and edematous. Also, we need to pay attention to possible thrombi or blood clots or even air embolism when it comes down to having IVs done or IVs in our patients. Other things that we want to look at are blood and blood components. The blood components are packed red blood cells, platelets, fresh frozen plasma, albumin, and other specific clotting factors. Also, RhoGAM is included in that, but RhoGAM is administered via IM. The biggest thing when it comes down to administering blood products is knowing what to utilize to do that. So when you are going to pick up your blood product from the blood bank, remember after the blood bank calls, you got 30 minutes to get that blood into the patient. After you pick it up from the blood bank, you got 30 minutes to run your blood. If it's packed red blood cells, when you get that, you got to make sure that you identify the blood with its identifier. Make sure that it has the correct number and relating to the donor. It has the correct product code, and you look at the ABO grouping and the RH type of the donor, and that's on the bag, because we want to prevent any type of sentinel events, which should not occur when it comes down to administering blood products if we do our proper checks. That's the biggest thing when it comes down to that, is making sure that there's another nurse that's there to verify you're giving the correct blood product to the patient. This includes platelets, fresh frozen plasma, and albumin. So administering IV medications, first and foremost, we look at medication safety, and that's why we do our 5 rights. We want to make sure it's the right patient, the right route, the right dosage, the right medication, and the right time that we're administering it. So when it comes down to figuring out what IV medications you're going to give, make sure you check out those lookalike drug names, because know that this IV is going straight into the bloodstream, so it's going into the peripherals, into the bloodstream, and you can have an immediate reaction. So make sure that we are checking those medications and we're looking out for lookalike drugs. The other thing is having a serious reaction, that adverse effect. That's what we look out for when we monitor our patient with any of the harsh medications that we may be administering. Just know that when it comes down to giving any IV medications, you have to be knowledgeable in certain things, such as you need to be knowledgeable when it comes down to knowing why drugs are being administered, any contraindications. You also need to know that if it needs to be diluted, what rate the infusion should be, and if it's compatible with any other medications. Also, as nurses, we should never assume that IV administration is the same as giving that drug by other routes. So we have to make sure that the medication can be given by IV prior to giving it, even though it's in that same bag, regardless of what the physician has written. The other thing that you want to look out for is when you're looking at the prescription, you want to look at the specific type. Again, going back to the rate and the route, either milliliters per hours or drops per minute. You need to figure that out. You need to establish if it's going to run to gravity or to an infusion pump. The other thing is you need to make sure that if there is a secondary line, like a secondary antibiotic that needs to be run, and you have a primary solution, then you need to make sure that that primary solution is compatible with that secondary and vice versa. And if you don't know what a primary solution is usually your isotonic, hypotonic, or hypertonic solution that's running in, and it's hung at a liter. And then your secondary is usually what's called a piggyback, like a smaller volume bag that is anywhere from 50 to 100 milliliters of fluid, and it runs in on a scheduled interval instead of a continuous interval. There are many different types of vascular access devices. The major types are short peripheral catheters, midline catheters, peripheral inserted central catheters, non-tunneled percutaneous central venous catheters, tunnel catheters, imported catheters, and hemodialysis catheters. We will talk about each individual catheter as we continue in this lesson. Peripheral IV therapy. Oftentimes we use the short peripheral catheters, most commonly in the acute care setting, as RNs. Basically, we utilize superficial veins of the dorsal surface of the hand or the forearm, and we utilize angiocatheters to insert. The dwelling time for this catheter is 72 to 96 hours. Then it's required removal and insertion into another site. Now, here's the thing. If your facility is at more of a risk of developing signs of infections at the site, then this time is actually cut down to 72 hours and not 96 hours. So you have to read your policy of your facility. Also, we look out for infiltration and phlebitis as well, not only with signs of infection. If your IV site becomes inflamed or infiltrated, or it starts to have phlebitis at the site, then we want to remove that catheter and we want to start it in a different place. So we utilize the BDN style AutoGuard IV catheter, and this is an example of one of the angio catheters that we utilize. There is a button that you push when you get into the vein and you get flashback in the actual hub. You push the button and the needle instantly retracts, and it reduces the incidence for needle injuries. Now, in order to know that you're in the right place, there's a couple of things that we could utilize to check to see if our catheter is actually in the vein. We can use transillumination, and there's a good figure in your book. There is an illuminator on figure 13-3. It's an AccuVein, so it helps you find the vein instead of just poking and priming, because a lot of times when patients come in and they're in some type of acidotic state, or if they've lost fluids, then their veins are vasoconstricted, or the fluid that's inside of the vein is very, very small, so it makes the vein small and harder to find it, so you can start an IV. So to reduce the amount of sticks, transillumination is used. Also, ultrasound guided peripheral IV insertions are also utilized as well. A lot of times you'll see this done in the ER. With that being said, the other things you want to look at is choosing your gauge and your size of your angiocatheter. Depends on what you're administering and who your patient is, and how long it's supposed to stay in the vein. So you have a good table on 13-1. It says choosing the gauge and size for the peripheral catheters. It goes over the different catheters. A couple of things I wanted to pull out was usually we utilize a 20 and a 22 that for just the common IV fluids that we're going to run, or the antibiotics. It says adequate for most therapies. However, this is a 22. Blood cannot infuse without damage. However, a 20, most providers of anesthesia prefer not to use a smaller size for surgery in this case. But a 20 has been utilized for blood products. However, we tell you to use an 18 gauge because that is the preferred size for surgery. And the vein needs a needs to be large enough to accommodate the catheter. And this is usually an 18 gauge is usually what we utilize when we are administering blood products. But 20 has also been deemed appropriate. But what I will say to you is, for testing purposes, always go with an 18 gauge first, and if there's not an 18 gauge available, then you can utilize a 20. Also, things to remember about utilizing the best practice for a short peripheral venous catheter. You want to make sure that you are utilizing the patient's non-dominant hand. You want to choose a distal site, and then make sure all subsequent venipuncture is proximal to the previous site. You also do not want to use an arm that a client has had a mastectomy in, maybe had an axillary lymph node dissection, lymphedema, paralyzed in the upper extremities, or dialysis, graft or shunt, or fistula. You want to make sure that you avoid choosing a site that is very valvy, as well as the vein is like it's cord-like and hard. You want to avoid choosing a site at a flexible joint, because anytime that joint is flexed, it's going to stop the fluid from going into the patient, which is going to cause your IV pump to beep. And you just want to make sure that it's appropriate for your patient, so the appropriate size, weight, or size, gauge, length for the medication or the fluids that you are administering to that patient. So infection control concerning short peripheral catheters, and this is it's across the board when it comes down to inserting anything into the skin, because this is an invasive procedure to your patient. But back in the day, actually short peripheral catheters insertions was considered to be a sterile technique. However, they figured out through the continuation of the actual procedure, it was difficult to maintain sterility because of you needing to touch the hub or touch the patient in order to disconnect the angiocatheter and then reconnect the saline lock to the hub of the angiocatheter. So it was quite difficult to maintain sterility and to do it by yourself. So basically, the CDC recommends an aseptic preparation and technique, including hand hygiene. If the client has an excessive amount of hair, clip the hair. Do not shave it, because you can nick that person and you can increase risk for infection. So clip the hair, do not shave. Ensure the skin is clean, wear gloves, and then utilize alcohol or chlorhexidine to clean the surface. The biggest thing is wear gloves, because I know a lot of you guys have seen a lot of nurses go in and start a short peripheral catheter, and they pop that pointer finger glove off to palpate, to feel for the vein, and they start the IV without changing their gloves. That is not aseptic technique. You always want to protect yourself, because you're coming in contact with bodily fluids. and you never know what those bodily fluids will contain. And you never know if you have a laceration on your finger. So you want to make sure that you're protecting yourself and the patient at the same time. So utilize standard precaution with this patient in aseptic technique. Okay, so midline catheters. Midline catheters are 3 to 8 inches long, about a 3 to 5 French. They can be a double or a single lumen. Things that you got to think about with a midline catheter is it almost looks like a PICC line, but it is not a PICC line. It goes into the basalic vein at the antecubital fossa space. Oftentimes, this midline catheter is utilized because the patient needs treatment for 1 to 4 weeks. But in your book, it does state that there's no recommendation time over the optimum dwell time for this actual catheter, but 1 to 4 weeks has been utilized for therapy, but usually the midline catheters stay in about 7 days or 6.9 days. With that being said, because it is an extended amount of time that the midline catheter is inside of that basalic vein, you want to make sure that strict sterile technique is utilized to insert it and to dress it. Also, in doing a midline catheter, a lot of times it can reduce the repeated IV starts for a patient, so it decreases their pain during the process if you're doing a short PIV versus putting this in and it's lasting. Also, it increases their satisfaction. The other thing you want to think about with a midline catheter, it's usually used for fluids to hydrate, and you can administer antibiotics, heparin, steroids, and bronchodilators for over a 4-week period. However, you got to think about what the fluids are and what pH and osmolarity they have, because this line is only contained to a pH between 5 and 9, and if the osmolarity of the actual fluid is less than 600. So we got to make sure that we watch out for that. You should not utilize a midline catheter if we know that the medication is going to be really viscous, or it's a vesicant medication, which means that it destroys the inner lining of the tissue with the repetitive use of that medication, the subcutaneous tissue. You do not draw blood out of these catheters. And you do not want to administer in these catheters incompatible drugs if you have more than 1 lumen. So this is just common sense when you're thinking about it. And the new midline catheter is called a Power Glide that you may see utilized. And of course, you have to be specially trained to insert this. And sometimes they use the ultrasound for guidance on the insertion. But sometimes they don't, so it depends on what's going on with this patient. Alright, so central IV therapy. This is vascular access placed in the central circulation, specifically in the superior vena cava near the junction of the right atrium. And so this actually sits right there at the tip of the right atrium. This is a more invasive IV therapy or catheter that is utilized. Chest x-ray must confirm it. A big thing that you want to think about when it comes down to a central line is making sure that the central line is appropriate in position, because the whole thing is that in the superior vena cava, there's about 2 liters per minute of blood compared to what's going on in the venous system. There's 200 milliliters per minute. So this medication is going to go in at a very, very fast rate, and it's going to affect your patient at a very fast rate. So we have to make sure that this is in the appropriate place, and that's why a chest x-ray confirms the placement of this prior to using it. So if a patient had just came and had a central line done, before you could administer any medication, you must do a chest x-ray to see if it's in the right place. Alright, so a peripheral inserted central catheter. This is what we call a PICC line. And I know a lot of you guys see a PICC line being utilized in Vibra. And the biggest reason why we use PICC line is because it is used for people that have injections of medications at a longer period of time. And it's the same as a central line because it goes into the same location, but it starts in a different place. So basically, the peripheral inserted central catheter actually is inserted into a vein in the intercubital fossa, which is most likely the basilic because the route is a lot straighter. And then the tip of the catheter is actually surfaced to the superior through the superior vena cava into the cavo-atrial junction. So right there at the tip of that actual right atrium. And you have a really good picture of it on page 193, figure 13-6. So when you're flushing the PICC line, and it may be a single lumen, double lumen, or a triple lumen, or when you're cleaning a PICC line, this is what you're doing. Remember, also, going back to cleaning the central line as well, these are sterile procedures when you do both of these. So you have to make sure that you utilize sterility because the importance of the landmark in which this catheter sits, you don't want infection dwelling in that catheter because it will ultimately get to the heart. So you have to make sure that you are changing and utilizing sterile technique when you're cleaning the hub to flush or to remove anything from it or to administer an antibiotic. Make sure you clean appropriately. And then if you're doing a procedure to change the dressing, you want to make sure that you utilize that sterile technique, not touching outside of the 1-inch border, touching the things that are properly are supposed to be touched. The other thing is wearing a mask and the patient wearing a mask as well. Anyways, moving on, when it comes down to a PICC line, we've already talked about that. Couple of things to think about is some of the complications with the PICC line is phlebitis, thrombophlebitis, and deep vein thrombosis and infection. And we've already talked about that. But here's the neat part about it. It actually says there's fewer infections with a PICC line than a central venous line because the arm is a cooler space instead of it being at the chest. So that's something to think about. There's no limitations with utilizing a PICC line when it's with its pH or its osmolality. So we don't have to worry about what fluids are being administered. The other thing we want to think about is utilizing the PICC line for a blood sample. It can be done. However, you want to make sure that the PICC line is a large bore French. And then for a patient that does have a PICC line, you want to make sure they avoid excessive physical activity in the extremity in which the PICC line is placed. No heavy lifting. And then you got to think about those people that a PICC line may be contraindicated in, like patients who utilize their arms for like mobility, like paraplegics. So we may have to go a different format for them. We may have to do like a tunnel central venous catheter for them because they have to utilize that arm, or we may have to do like an important implanted port. So it just depends on what's better for that patient. So when you're thinking about a client that is that has a PICC line, major components to prevent any infection for this patient, make sure you hand hygiene. So wash your hands, utilize precautions in barriers of insertion. You can use chlorhexidine for a skin antisepsis, but just making sure you do the things that you've been taught to do as a nursing student. Alright, so a non-tunnel percutaneous central venous catheter. This is a catheter that is usually inserted by physicians or PAs or trained NPs into the subclavian vein. This is what I call an IJ. This is an intrajugular vein catheter. It's usually used in emergency situations where venous access is very difficult to get through to. A lot of times with this on insertion, there must be a chest x-ray to confirm it. But with that being said, this patient must be placed in a Trendelenburg position, and there must be a roll or a pillow between the shoulder blades in order for it to be done. Now, there are some contraindications. So if this patient is having some respiratory issues, has some spinal issues, has increased intracranial pressure, this may not be the route to go for them. Also, if they have a tracheostomy, this may increase the risk for infection. So we want to make sure that we utilize the correct catheters in order for us to gain access, that it won't cause them any more complications. The other thing about this IJ is it actually does sit in the superior vena cava as well. So the rate of infection is can be high, especially depending on how you decide to utilize the IJ and if they have any other chronic conditions or emergency conditions. All right, so tunnel central venous catheters. A tunnel catheter is portion of lines in the subcutaneous tunnel, and the other portion is actually underneath the skin. There's a great picture of it on page 195 and figure 13-8. So basically you have the outside catheter and then you have the rest of the catheter tunneled in under the subcutaneous tissue. Um, so this is usually performed by a physician in the radiology suite. Basically what happens is you have that catheter that is lying outside of the subcutaneous, and then it's tunneled through the subcutaneous, and then it enters the vein where it exits the skin. So this is oftentimes utilized in patients that are going to have frequent and long-term infusion therapy. But a good thing about this is that the cuff, so the outside cuff and the inner cuff, is actually aligned with an antibiotic to reduce infection. So that was my first thought process with a tunneled central venous catheter. Isn't it going to collect germs around those that is outside of the skin, because the entire catheter is not inside of the vein? That was my concern. But these cannulas are actually covered with antibiotics, so that's always a great thing. You can have single, dual, or triple lumens. These catheters are oftentimes called the Hickman and the Leonard catheters, the Braviac catheters. So you may see those being utilized. Also, these patients that may be needing this may need parenteral nutrition for months, years, or the remainder of their life. So this may be utilized as well. Or remember we talked about that PICC line that could possibly be contraindicated with the paraplegic. Well, this paraplegic may go for having a tunneled central venous catheter. Now, there are some people that don't like to see the peripheral catheter on the outside, or they don't really like the thought process of being punctured. So if they don't like the thought process of being punctured, then they want an implanted port, and that's what we're going to talk about next. But if they don't like the thought process of the tunnel hanging outside of the chest, then they may go for a tunnel or an implanted port. So an implanted port consists of a portal body, a dense septum over the reservoir, and a catheter. It can be a single or a double. There's a surgically created subcutaneous pocket in which the body lies, and that's where you puncture it. Usually placed in the upper chest or the extremities. It's non-visible externally. And so when we're talking about implant port, a couple of things that I wanted to pull out is that if you press on the actual port, then the patient may exhibit some pain. So you want to be careful of that, but you do have to press on it to assess to see where the body of the actual port is. The port can lie in the subclavian or the interjugular vein. Also, with that being said, you got to think about a couple of things when you get ready to puncture it. So, port access, you got to think about what you should be doing and how you should be doing it. You should be wearing a mask, as well as it needs to be aseptic technique. So remember I said before puncturing it, you must palpate the body and the septum to see where you're going. Just know when we're talking about the septum, when you insert, so you're utilizing a needle to insert, and the needle actually has kind of like a deflected tip. It's called a hubber or Huber, whatever you want to call it. So when it goes in to puncture it, it has a tight relationship with the septum, and so when you pull out, sometimes you can have a rebound needle injury because it's held so tightly that the pressure behind it won't let you pull it out like you think you should. And so when you pull it out, sometimes it goes back, and then you pull it out again, and it may come out too fast where you poke yourself. So be careful with that. When it comes down to flushing the chamber, utilize heparin. It says 5 milliliters of 100 units of heparin per milliliter. Sometimes you have to utilize some type of topical ointment to decrease the pain if that area is very, very sensitive to a patient prior to accessing the port. So this is just a picture of the implanted ports. On the left, you have a dual lumen implanted port for the venous access. On the right, you have a non-coring needle with the safety mechanism, the Hoover, actually being utilized into the port point so you can see how to access it. So the hemodialysis catheter is a large lumen accommodated for hemodialysis or apheresis procedure. So this is utilized to help people that have chronic renal failure that need their blood to be filtrated. This is what's utilized. It's usually a combination or an anastomosis, of a vein and an artery. And when that vein and artery is done, then you have a catheter that you utilize to engage in that. So a little bit about this is something that we oftentimes are concerned about is infection and vein thrombosis when it comes down to these catheters. Heparin is utilized to keep or prevent clots from happening. And we do not use for administration of fluids or medication except in an emergency. So those are the things you need to pull out about that. So the infusion system has all been reviewed to you when it comes down to your skills 1 and 2 and in your clinical that you've had thus far. What I want you to do is I want you to review the rest of this information for the infusion system. So look at containers, administration sets, look at rate control infusion devices. So you can have this knowledge for you. So when it comes down to the test, you'll have this information, but it's easy read. It's stuff that you already know. It's just a review. So a couple of things to remember when we're talking about the infusion systems is your changing of your tubing. So if you're giving lipids, change it every 24 hours. Blood tubing should be changed within every 4 hours. And then if you're giving Profilol, your tubing should be changed every 6 to 12 hours. And then what I want you to review is your nursing care for your patients receiving IV fluid. Again, this is a review for you. So educating the patients, performing an assessment, securing and dressing the catheter, changing the administration set and needles, controlling infusion pressure, flushing your catheter, obtaining blood specimens, removing vascular devices, and then documenting your IV fluids. All of those things you've done before. So I just want you to read over that yourselves. So there's a great chart in your book that goes over all of these complications for you starting on page 204. And it talks about infiltration. It talks about phlebitis, thrombosis, extravasation, hematomas and ecchymosis, site infections, venous spasms, nerve damage, circulatory fluid volume overload, speed shock, and then catheter embolus. Please review all of these because I don't feel like I need to go through each of them and review them with you. Know what they are, know what the signs and symptoms, what do they look like, of course. What your treatment is, so what you should do for them, and possibly the preventions. But the biggest thing that I'm going to focus on, is your signs and symptoms and your treatment and knowing what they are. So I skipped a couple of sites earlier that I felt like they were really self-explanatory, so just read over those. But other alternative sites that we may utilize for infusion, and if you don't know, I want you to know this. In your book, let's start with the subcutaneous therapy. It is the most commonly used administration for pain medication and insulin therapy. This is using the subcutaneous tissue to run IV fluids. It's called hyperdermocliasis or cliasis, and it's when basically you administer IV fluids through the subcutaneous tissue. You can do this to help with fluid resuscitation. It was done like way back in the day. However, there's a limit. It's not appropriate for emergency, and it should not exceed 2,000 or 3,000 milliliters per day, or exceed 1,500 milliliters in a single infusion. So there is a stipulation on that. The other one I wanted to pull out is your intraosseous infusion. This is like straight infusion into the red bone marrow. It's usually utilized for pediatric patients. However, people that have like immediate traumas like burns, cardiac issues, diabetic ketoacidosis, life-threatening conditions that they cannot get to the vascular system, they can utilize IO. And it's usually done in a pre-hospital setting, so in the ambulance if there's an emergency situation. The only absolute contraindication with IO that you cannot utilize is having a fracture to one of those long bones. And the sites are the proximal tibial, the distal femur, the medial medialis, proximal humerus, and the iliac crest. There are some complications, but it's not commonly seen. Osteomyelitis may be a complication, and the other contraindication is that if they had any type of disease process that will cause their bones to be very, very brittle or weak, like osteoporosis, osteopenia, then it would not be utilized at that point. The intra-arterial infusion therapy, it's utilized if a patient needs repeated arterial blood samples. So this is more of in your ICU area. And if you need to infuse high doses of chemotherapy, it can be utilized as well. The intraperitoneal infusion therapy is administered for chemotherapy agents. It is utilized there's a catheter that's utilized and placed in the intra-abdominal cavity. And it is basically utilized for abdominal malignancies, and there are 3 different phases of this. There's the instillation phase, the dwell phase, and then the drain phase. Something to think about, like in the instillation phase, the client should be in a semi-Fowler's position. In the dwell phase, the client needs to be rolled from side to side so the medication can get to the abdomen, so where it needs to be. And the biggest thing is that the exit site, there is an increased risk for infection. So you want to make sure that you document any redness or tenderness or warmth where the catheter is, because it's in that peritoneal space, and you have that mesenteric artery system that can cause a persistent and rapid sepsis to that patient. Intraspinal, 2 things I wanted to pull out in the intraspinal. You have your epidural and you have your intrathecal. Your epidural is the space between the dural matter and the vertebrae in the subarachnoid space, and the intrathecal is between the dural matter. So these are 2 types. Usually your intrathecal is considered a spinal. Your epidural catheters can be used for a long period of time. They are tunnel catheters. But with that being said, when you're using both of them, you want to assess patients to responses of the drug being given, their level of alertness, their respiratory assessment, and any type of itching they may have, because it's usually what happens. If anybody's ever had a baby, they had an epidural, you have that side effect. And the other thing is respiratory depression is really, really big, because if the catheter flips up with the tip, then all the medication goes upward, and it stops the patient from breathing. Compartment syndrome is very short and sweet. It says when there's an increase of perfusion in a confined space caused by a decrease of flow in an area. So basically you have
you have fluid emptying into a space and there's nowhere for it to go. And so you have basically a decrease of circulation of the limb. You have coolness, swelling, and mottling and discoloration. So just look out for that. So, of course, in our geriatric clients, we have a lot of things that we have to look out for and take into consideration. One of the biggest things in reading this lecture and in this text that I have done as a nurse but really didn't think about is how you go about choosing the correct vein for an elderly patient, and then how many attempts, because you got to think about this. Number one, they have thinner skin, they have very small subcutaneous tissue, and so when you go into puncture or utilize a catheter to puncture a vein, it may take many times because they may be dehydrated, so the veins may be smaller. They may have a condition or a medication that they're taking to cause vasoconstriction. So you got to think about this when you're doing this on them. The other thing is the catheter may not stay in long as well, because the medication can cause the vein to become even thinner than what it is. So make sure when you're doing this, you're getting ready to start a vein. We do not utilize a lot of friction on their skin because it can cause skin integrity, impaired tissue integrity, sorry. We oftentimes don't use alcohol. You can use chlorhexidine on them. If you need to remove the hair, of course we don't shave because it can cause nicks. We usually clip. Other things with choosing a vein, stay away from small or tortuous veins, any valvy veins. We don't oftentimes utilize a tourniquet on older adults because it can cause hematomas if left on too long. So we can use a blood pressure cuff. We can tap lightly on their vein. We can ask them to open and close their fist. We can use a warm compressor. We can tell them to lower the extremity below the heart. We don't oftentimes go in at the same angle. We go in at a low angle, usually about 10 to 15, same as like a TB screening or PPD screening that you're going to do. So it's a little bit different. Sometimes midline catheters or PICC lines are best for these clients because of their disease process, poor skin turgor, dehydration, all of that good stuff. The biggest complication that we worry about with clients that are older receiving fluids is fluid volume overload, which can push them into having congestive heart failure. And then things we want to think about is, there's renal changes, decrease of GFR on these patients. Are they going to be able to excrete what we give them? And so sometimes we got to decrease their dosage as far as fluids and antibiotics because of the renal system. All right, you guys, so let's look at some questions for chapter 13, and hopefully these will help you get through the rest of this chapter. All right, so let's look at these questions. So what is the primary intervention of a nurse? Intervention the nurse can implement to prevent a central catheter-related bloodstream infection for a patient having IV therapy? Well, of course, hand hygiene is number one. So make sure that you wash your hands as a nurse. All right, so a man was with severe burns. Over 90% of his body has been brought to the ED. The rescue personnel was unable to establish an IV access during transport to the hospital. Which type of IV would be most appropriate at this time? So you got to think through this whole process and what the question is asking you and what they included. So not a PICC line, not a central line, not subcutaneous infusion, because this client has over 90% of burns of his body. So here's the thing. The correct answer is intraosseous catheter. So it says the rescue personnel were unable to establish an IV access during the transport of the hospital. So they were unable to establish anything. So we got to go with an IO on this patient. Okay, so during the insertion of an IV catheter, a patient with dehydration reports feeling pins and needles in his arm. The nurse is aware that this sensation may be caused from what? So let's look at it. The nerve puncture may have occurred. The patient's dehydration causes the sensation. I've never heard of that. The vein has collapsed during the catheter insertion, but it wouldn't cause pins and needles. And the vein has been accessed properly for the infusion. Well, that wouldn't cause pins and needles as well. So the only correct answer is pins and needles. Anytime you see that, there's a nerve problem. Okay, so A is the correct answer.